Hi, everybody, and welcome again to Conversations in Interventional Cardiology. My name is Sahil Parikh from Columbia University in New York, and I'm delighted to be here on behalf of our SCAI team and editor-in-chief Alexandra Lansky to really present an important but really underserved topic, and that is chronic venous disease. I'm delighted that today we'll be talking about the 2025 SCAI Clinical Practice Guidelines for the management of chronic venous disease, and we have a great panel with us. Presenting the paper will be Dr. Robert Attaran from Yale New Haven in New Haven, Connecticut. Rob's the Interventional Cardiology Training Program and Endovascular Training Program Director. We also have Pamela Kim from the Center for Vein Restoration in Framingham, Massachusetts, and Jeff Carr, who's an interventional cardiologist at Christus Heart and Vascular Institute in Texas. And Jeff is a leader in the movement from inpatient to ambulatory care in interventional cardiology. So we'll have a lot to talk about that. So without further ado, Rob, do you want to go ahead and present your slides, and we'll have a panel discussion after that.
Thank you very much, Sahil. It's a pleasure to have the opportunity to present these guidelines. Over almost the past 3 years, SCAI has embarked on this endeavor to put together clinical practice guidelines for the management of chronic venous disease. And as you all know, venous disease is extremely common, even commoner than peripheral arterial disease. We have over the past years seen an increase in the number of procedures being performed, including by cardiologists. And in fact, a lot of patients with venous disease are under the care of cardiologists, and that also includes patients with leg edema. But as it happens, training in the management, evaluation, and treatment of venous disease is not really covered very well in fellowship, including even sometimes in an endovascular fellowship. And as a result, a lot of practitioners are not fully versed in what they need to know. To help with that, we put together a wonderful group of vascular surgeons, interventional cardiologists, vascular medicine specialists, as well as statisticians and methodologists. And we went through over an extensive period of research through the data out there published in the treatment of venous disease. And we conducted a systematic review. First, we utilized the GRADE methodology, which assesses the quality of the evidence out there and ultimately ends up presenting the data as best as possible and provides strong versus conditional recommendations from it. We ultimately had 8 root PICO questions that look at a particular intervention versus, in our case, conservative therapy, and came together and created guidelines for the management of various aspects of venous disease and interventions. But we also, in addition, put together some very helpful tips with regards to patient selection, procedure selection, some great nuances, as well as algorithms that were designed to help the venous practitioner. Ultimately, though, the best thing is that these guidelines are very concise and easy to read. We looked and assessed the merits and the indications for compression, saphenous vein ablation, accessory ablation, perforator ablation, and sclerotherapy, phlebectomy, and even deep venous intervention in chronic venous disease. And often these were compared to conservative treatment. Ultimately, we also put together, derived from our findings, some suggested algorithms. This one you see here talks about the treatment of C2 to C4 disease, and ultimately it's good to start with conservative measures such as stockings or weight loss. But if patients have significant symptoms, then they can utilize this algorithm to perform a reflux study. And if, for instance, they have saphenous vein reflux, then that can be treated. If they have varicose tributaries with reflux, and those could be treated with phlebectomy or sclerotherapy, but we did not make a recommendation for perforator ablation in the setting of C2 to C4 disease because there's a lack of evidence. And finally, for C4 disease, patients may merit deep vein evaluation if symptoms are not improving despite the other treatments. And we also put together an algorithm for venous ulcer disease, which is a costly and a very problematic condition. And in the setting where there may be reflux, we created guidelines on suggested treatment pathways, which would start with treating saphenous reflux if it exists onto accessory reflux and perforator reflux if the perforator reflux is associated with an ulcer and ultimately deep vein disease. And thank you. And that's the end of our slides. And I'll stop and allow the group and the panelists to comment about our findings and our guidelines.
So Rob, thank you very much for presenting your findings. All of us were on the panel, some more or less involved, myself less, and the rest of you more. But I think that the importance of this document can't be underestimated. I think, as you pointed out, the prevalence of venous disease is enormous. And if you live in New York, there's a vein center on every corner, it appears. And the implication is that there is a lot of inappropriate behavior in terms of practice out there in the community. But the truth is there's a lot of symptomatic disease. It's under-recognized and even more heterogeneously managed and treated. And interventional cardiologists have to be able, like all practitioners, to identify and refer, if not treat, when appropriate. So, Jeff, I'm going to start with you. You've been in practice for a few years. Tell me about how these guidelines help to bring some clarity to what is otherwise a murky area.
Well, you're right, Sahil. I got into venous disease over almost 20 years now, so I think I was kind of an early adopter as a cardiologist and trained literally hundreds of cardiologists. And since that time, and really back in the day, there really weren't good guidelines like this. There wasn't an evidence base that was easily drawn upon. And so I think for a practitioner that's just getting started or in the middle of kind of growing their practice, I think these guidelines are really helpful to really level set what the evidence really is in terms of the randomized clinical trials. And I think I would emphasize that really this effort was based predominantly on randomized clinical trials. And so, it's very apparent as we went through this exercise that there's a relative paucity of data in terms of the RCTs. We have a lot of observational and retrospective and case studies, but just like most fields, we always need more evidence-based, more higher level evidence to guide us. Having said that, there's the real world, and we have to take care of patients in front of us, and there's a quality of life issue that is so much a part of taking care of patients with venous disease, as I've done this for the last 20 years or so. And it's very gratifying in that sense because patients get better with treatment. And, there's conservative treatment, but also the interventional, as we're really highlighting in this effort, comparing the two. And so I think this is really helpful that it can be drawn upon, it can be referred to, but of course they're guidelines. They're not prescriptive in terms of how we need to act.
Pam, in your practice as a busy clinician, how do the guidelines help you reframe the conversation with your referring doctors? How are you going to use these guidelines, not just as a practitioner, but also as an expert in the space?
Thank you for that. I think especially the fact that they're so concise and we're able to provide the algorithms, that is a very easy tool to be able to utilize. And that's going to be an excellent way to show primary care providers or any other referrers, including dermatologists or podiatrists or whoever else is going to refer to you. Hey, look at this. Do you see any of this sort of issues with your patients? This is when to refer. And going back to what you had said initially about how there's a lack of training, venous training, especially in fellowships, my background is in vascular surgery. And even in vascular surgery fellowship, superficial venous disease or even deep venous disease was rarely touched upon. And it's something for newer practitioners, especially, to be able to easily refer to in all fields, especially those algorithms. There's very few resources out there that have it in such a nice, easy to read reference.
Yeah, I mean, Robert, I mean, you deserve the kudos for having the intestinal fortitude to bring this from inception to over the goal line. As you look back upon this labor of love, what are you most proud of? Where do you think there are research priorities that need to be filled, and how do you think that version 2.0, believe it or not, we already have to think about version 2.0. How is that going to maybe look different than what we've done so far?
Thank you for that, Sahil. You know, doctors want to do the best they can for the patients, but everyone is busy, and we end up being very siloed. And venous care ends up being one such example. So our hope was, by putting together this collaboration, to come up with not only the guidelines so people know what is out there, but also some tips and suggestions on how to take care of patients. And going forward, we know that there are gaps in the literature. There are patients who have recurrences over time in deep vein intervention, which has really taken off in terms of stenting, both for thrombotic as well as non-thrombotic lesions. We really have very little data or very little long-term data on what happens to these patients and who will benefit from it. Many patients with just leg edema, with leg swelling, get venous stents placed, and it is unclear how many of those patients actually improve. My experience is at best a half. So there's a lot more people need to learn as to who are the patients who benefit, for instance, from stenting. Who are the patients who are best served with, say, a thermal versus non-thermal ablation? Should we treat below the knee or not? Should we do sclerotherapy or not? Should we do sclerotherapy together with another treatment? So there are a lot of gaps in the literature that have yet to be understood.
Yeah, so I mean, I think that the nice thing about these guidelines is that they will sort of stand as a living, breathing document, and as the society has endeavored, all of the guidelines tend to be updated on a much more regular basis than the traditional society guidelines, which are usually every decade or more. And as with any field, this is a dynamic field in which we expect that we'll see a lot of changes over the coming, decade, and we're hopeful that there'll be many opportunities for us to teach and train towards these guidelines. I know as the SCAI scientific sessions will be planned for next year, there'll be a lot of conversation about this document, and we also look forward to having not just the manuscript in print, but also multiple conversations in interventional cardiology on venous disease in this series of sessions going forward. So with that, I want to thank all of my partners here on the panel, and I want to thank all of you for listening. This has been Conversations in Interventional Cardiology. My name is Sahil Parikh, and I'm delighted that you were able to join us. We look forward to seeing you next time.